I'll be very briefly covering the rest of the tumors, that is epithelial and melanocytic, which are of course the most common ones of conjunctival tumors, and also dealing with the management. Rest of the instructors have abandoned me for better sessions, I suppose. All right. So why do we know about ocular surface tumors? Because these are most easy to diagnose. You don't need a specialized equipment, you don't need an expensive fundus camera, you don't need angiography, you don't need nothing. You just need a slit lamp evaluation and some knowledge, because what the mind doesn't know, the brain can't see, or otherwise, what eyes can't see. So, and these are most common of ocular surface tumors, most common of all tumors. In fact, if you look at all intraocular tumors, orbital tumors, eyelid tumors, etc., or have a data collection of all the tumors that you can get in the eye, ocular surface tumors comprise of about 50 to 60% of all tumors. So they are most common. But the most important aspect here is that 50% in adults can be malignant, and of these, 20 to 40% have reported local tumor recurrence. That means that if you excise them properly, obviously you'll have no local tumor recurrence or minimal of that. But if you don't excise them, or if you don't follow a protocol-based approach, then you have a very high chance of local tumor recurrence, thus predisposing the patient to regional lymph node metastasis and systemic metastasis, and even loss of vision, loss of an eye, etc. But then if you use a protocol-based management, you can reduce the local tumor recurrence to less than 2%, and that is true. In a busy clinic, you will be inundated with lesions of the conjunctiva, some of which may look like pterygium, some of which may look like pincula, some of which may just look like a cyst. There are many cases that were shown by SEMA, which could be very confusing for a clinician who is a general ophthalmologist, or somebody who is a cornea specialist, or a retina specialist, or a cataract surgeon. But in the middle of which would be hidden something very sinister, and that could be a tumor. And how do you identify all that? It's very easy, because each tumor comes with a signature. Each tumor has a very specific clinical feature. If you look at it, you'll be able to identify. And that's how you'll be able to recognize. SEMA has covered everything except epithelial and melanocytic, and I'll cover what is left. Now, epithelial tumors can be further classified as squamous epithelial tumors, which are benign, papilloma, hereditary benign intraepithelial disc keratosis, which we will not cover because it does not happen in India. It happens in triracial individuals who are called Navajo Indians in the United States, especially in the North Carolina and South Carolina provinces. Pre-malignant and malignant tumors, ocular surface squamous neoplasia, because it's a encompassing term which includes dysplasia, which is a pre-malignant lesion, carcinoma in situ, and invasive squamous cell carcinoma. And there are other epithelial tumors as well. The diagnosis here is very clear. Why is that? Because you find a papilliform lesion with a central vasculature from which there are blood vessels which are emanating, and there is a bunch of feeder vessels as well. So this is conjunctival papilloma. How do we say it is papilloma? Why not a papilliform ocular surface squamous neoplasia? Because there is no keratin. So if a conjunctival lesion has a papilliform architecture but no keratin at all, and has feeder vessels, irrespective of that, your primary clinical diagnosis would be conjunctival papilloma, and you can keep ocular surface squamous neoplasia as a differential diagnosis. And also it is in the area which is not in the interpalpebral vulva conjunctiva, because ocular surface squamous neoplasia is most common in the interpalpebral vulva conjunctiva. This is in the inferior vulva conjunctiva. This is also a papilloma, but this is in the lower eyelid. Somebody has excised a papilloma here, but now this has happened here. Again, you see in the magnified picture, there is a central vessel from which there are radial vasculature. So it looks like this in magnification. There is a central large vessel from which there would be radiating blood vessels. That's a very typical architecture which will not miss on slit lamp evaluation. And there is no keratin. Generally does not happen in the interpalpebral vulva location, generally. It's caused by human papillomavirus type 16, 11, 6, 33 and 45 are also possible. Now, who does it get infected with HPV virus? Anybody can get infected with HPV virus, not just females, males as well. And those who are immunocompromised can get obviously more infected. But the solution to this is now HPV vaccine. With the onset of HPV vaccine and that being available, in fact, a pentavalent vaccine is available against all these strains in India currently, which pubertal girls are being administered. And in fact, immunocompromised individuals can also get the same vaccine. In fact, there are reports in the literature saying that people who were administered this vaccine had a complete remission of papilloma. In fact, even ocular surface squamous neoplasia, which was produced by a pre-existing papilloma induced by HPV-16. So even vaccination can treat some of these patients. That looks like a very aggressive lesion, but that is also a papilloma. You can see a very clear architecture. Now, in a situation like this, we'll get very confused because this is in the interpalpebral vulva location, very aggressive looking lesion. It could be squamous cell carcinoma, but on excision, it turned out to be a papilloma. So papilloma have a spectrum, some of which look like very typical, very benign. Obviously, they live up to what they appear to be, but then some of them look like this, very aggressive, but they tend to be papilloma on excision. But then you can't take a risk. So whenever you have a conjunctival lesion which is appearing borderline, you have to give it due respect and excise with clinically clear margins. Some papillomas can look like this, pigmentation. So pigmentation is only seen in dark-skinned individuals, Asians, and also the South Americans or anybody who has some amount of skin pigmentation, not in Caucasians. Again, you find architecture here, the blood vessel, radiating blood vessels from it, but this part is pigmented. This is not melanoma, this is a papilloma which is intensely pigmented. This was a Mongolian patient who was referred after he was excised 3 times and he had a recurrent lesion. This has the entire ocular surface involved, and not just that, it was in the nasolacrimal duct as well, and through which it was in the nose. So it had a large papilloma. So we could vaporize and excise most of the conjunctival component. We had to do dacrocystectomy and fulgurate the intranasal component and treat the patient with systemic interferon, and that actually settled it. So there is an argument to use interferon in papilloma, and also in the West they use cimetidine and levomazole, which are immunomodulating agents. They boost immunity for a temporary time, and that actually can help resolve papilloma. So that is some of the options, systemic therapeutic options that you have in these patients. This was a child with an aggressive papilloma, thrice excised elsewhere, again recurrent. This we didn't excise at all. This was treated with systemic interferon, and the child had complete regression. So in aggressive recurrent papillomas, you can opt for systemic interferon, which your oncologist will help you give. Now, when a papilloma is atypical, then you should worry about it. This patient has a typical papilloma here. This patient is immunocompromised because she has undergone renal transplantation and she is on post-transplantation immunosuppression. This is a typical papilloma on the right eye. In the left lower lid, she has a papilloma which has a broader surface and a much broader base. So this papilloma is looking like this. The surface is ulcerated and a much broader subconjunctival base. So then you should worry because papilloma is inverted here. This is called inverted papilloma, and that has a very high chance of having coexisting squamous cell carcinoma transformation. So in an immunocompromised patient, when a papilloma looks broad-based, then it could be squamous cell carcinoma. Well, is this papilloma? It looks like papilloma, but you can see that the patient had a large chalazion which has burst, and that is a subconjunctival extension which ultimately got extended to the bulbar conjunctiva as well. This was just a pyogenic granuloma. I'll skip the Navajo-Indian thing. All right, so we'll go to, right. Yeah, what does this look like? This has a corneal pannus, vascularized one, loss of definition of the limbus, and cornea specialists may call it acquired limbal stem cell deficiency, right? And they miss the tumor that is staring at you. Do you think it is ocular surface squamous neoplasia? Possibly, it could be, right? But your ocular surface examination is never complete until you evert the lid. When you evert the lid, you find that this is the normal lid margin. Here the lid margin is thickened 3 times. This is the normal sharp posterior lid margin which you see on eversion. This posterior lid margin is all destroyed and rounded, and you see no meibomian gland orifices in the lid margin at all. So that immediately makes you suspect that it is actually a sebaceous gland carcinoma, pegytoid variant. So in a sebaceous gland carcinoma, what are lost are meibomian gland orifices because it's a tumor of the meibomian gland. The posterior lid margin gets rounded, and the lid margin gets thickened apart from a conjunctival lesion. So this is a pegytoid sebaceous gland carcinoma, does not have a large tumor that you're used to seeing. So any patient with unilateral blepharoconjunctivitis with what looks like an ocular surface tumor, you should suspect pegytoid sebaceous gland carcinoma. Now, this looks exactly similar, isn't it? This is a different patient. This is a different patient. Looks exactly similar. But the diagnosis is different. That's because you see white dots here. These dots are nothing but keratin. So whenever a patient has a conjunctival lesion with keratin, that means it is an epithelial cell tumor, which a high epithelial cell turnover. Keratin is a byproduct of high epithelial cell turnover, and that is ocular surface chemist neoplasia. So one signature for OSSN is presence of keratin. So whatever may be the tumor, whatever may it look like, but if a tumor has keratin, then you should think of ocular surface chemist neoplasia. This was diagnosed as peripheral ulcerative keratitis. A cornea specialist has done a conjunctival resection, glue BCL for the peripheral corneal gutter. But what was missed here was this patch of keratin. This was squamous cell carcinoma with scleral invasion. So it can present as peripheral ulcerative keratitis. There's one more case here which can also look like peripheral ulcerative keratitis, not to miss the scleral nodule. So these are not immune-mediated peripheral ulcerative keratitis. That corneal gutter is because of tumor infiltration into the cornea and the limbus, and the nodular component is very evident. One more situation which may look like peripheral ulcerative keratitis. So when a patient looks atypical for peripheral ulcerative keratitis with a scleral nodule or keratin, you should suspect OSSN. This looked like a sterile corneal melt to a cornea specialist. He did what he could. He did a patch graft. Very nice patch graft indeed, but when he sent this necrotic material to the pathologist diagnosed ocular surface chemist neoplasia. Why was it missed? Because all this keratin was cleaned out by the fellow before the consultant saw it, and there was exuberant keratin, which already tells you that you are dealing with a corneal melt. It is of course a sterile corneal melt that is induced by tumor infiltration and not because of immune-mediated scleritis. I'm the only speaker left, so this is my course, so please don't keep buzzing. At the end of the time, I'll finish. Necrotizing scleritis. This is definitely necrotizing scleritis, but not immunologically mediated necrotizing scleritis, but a tumor-induced necrotizing scleritis. You can see exuberant keratin again. So what I'm trying to stress upon is the fact that keratin is one of the signatures of ocular surface chemist neoplasia, and that will help you diagnose it in atypical situations. The second signature is abnormal vascularity. This patient had undergone a phototherapeutic keratectomy because the cornea specialist thought it was a corneal scar. Actually, it was and it is at the level of the epithelium. You can see that, right? And when you look at it closely, you find abnormal blood vessels here. So this is a ocular surface chemist neoplasia with a predominant corneal epithelial component. The epicenter of the tumor is here, which is much flatter and subtle. So you can miss this subtle tumor, and what looks like on the cornea is a corneal scar or maybe a epithelial issue, related issue. Rolika, can you tell them not to do that? Yeah. So here we have abnormal vascularity, that is a signature of the tumor, and that is ocular surface chemist neoplasia. So these are all the masquerades of ocular surface chemist neoplasia. Each one looks different. When each tumor looks different, how can you be sure of the diagnosis? You can be sure of the diagnosis by looking at 2 or 3 major or important clinical features. One is its interpalpebral bulbar location and its epicenter being the limbus. A limbal lesion which has some amount of extension onto the cornea, some amount of extension onto the sclera with abnormal vascularity and bits of keratin is definitely ocular surface chemist neoplasia. Some of these may not have keratin, but they still carry this abnormal vascularity, feeder vessels and intrinsic vascularity, and they transgress the limbal barrier and go on to the cornea. That is a very typical fleshy appearance of OSSN. Some of them look like papilliform. They look like conjunctival papilloma, but at the same time, you can't miss this corneal epithelial invasion, which does not happen with papilloma. Papilloma can overlap the cornea or hang on to cornea, but it does not infiltrate the corneal epithelium. Any lesion that has a corneal epithelial infiltration, you should consider as ocular surface squamous neoplasia. This is a nodular lesion, very elevated lesion, but you can not miss the limbal location. You can't miss the scleral and the corneal component and the abnormal vascularity. So I'm showing you a bunch of cases which are ocular surface squamous neoplasia, each of which is different, but the commonality here is the location, epicenter being the limbus, corneal epithelial component and the scleral component, abnormal feeder vessels and intrinsic vascularity and keratin. So all these patients have different morphological variants of ocular surface squamous neoplasia. Some of them can be even pigmented, and about 15% of OSSN in Asian Indians happen to have pigmentation. Do you think this is ocular surface squamous neoplasia? This is a differential diagnosis. It is an interpalpebral bulbar location, but it is away from the limbus, right? Limbus is not affected at all. OSSN is a tumor of the limbal stem cells, so it is not at the limbus. There is no corneal epithelial component. It has this pearly white configuration, but abnormal vascularity. This happened to be a large molluscum, conjunctival molluscum, which can happen generally in the eyelids. This was conjunctival. This is benign hereditary intraepithelial dyskeratosis. This is seen in triracial individuals. This looks like OSSN. Again, it is not at the limbus, slightly away from the limbus, a fleshy lesion. This was a conjunctival pyogenic granuloma. Right, so very typical lesions. This is again a conjunctival pyogenic granuloma in a situation where a pseudopterygium has been excised, and you see exuberant scar tissue that has formed in the area where pseudopterygium has been excised, and that is a conjunctival papilloma. So you should be knowing about the differential diagnosis as well. That's a pyogenic granuloma of the lateral fornix. So the morphological features are very important. Now to sum it up, the morphological features, if you have a patient with a conjunctival tumor, if it has keratin, then that has 80% sensitivity and 92% specificity to the diagnosis of OSSN. Now, apart from keratin, if it has abnormal vascular pattern, feeder vessels and intrinsic vascularity, then that increases the sensitivity and specificity quite significantly. If you're still confused, instill a drop or just use a rose bengal strip and stain the conjunctiva with rose bengal. If there is rose bengal staining of the lesion, all these pink areas are stained with rose bengal, then your diagnostic sensitivity and specificity are extremely high. You're as good as the gold standard, that is histopathology. Summary of this slide is, if you have a conjunctival lesion which may look like pterygium, pinguicula, conjunctival scar, anything for that matter, but if it has abnormal vascularity, keratin, and it also stains with rose bengal, then you should treat it with a lot of respect and treat it like ocular surface squamous neoplasia. These are your triad of clinical signs. Right? Apart from that, if you're still confused, you can use this very important and easily available tool, anterior segment OCT. Again, it has three signs. This was described by Dr. Carol Karp. One is normal corneal epithelium is grayish and about 60-70 micron thick. When it becomes hyperplastic, that means it becomes taller, hyperreflective, it turns white, and it abruptly ends like this with a snout-like ending. So hyperplastic, hyperreflective corneal epithelium which abruptly truncates are the triad of signs of ocular surface squamous neoplasia on anterior segment OCT. So if you have any doubt at all, you can do anterior segment OCT and diagnose it. These are all situations where ASOCT has been performed, and you can actually see that it mimics the histopathology finally. So ASOCT and UBM are very good tools in diagnosing OSSN and also determining the depth of the lesion or the base of the lesion, which becomes very important. This is a corneal OSSN. This is the normal corneal thickness. In this area, cornea is splayed or it's become thicker, and there is intrinsic vascularity within the corneal stroma. So this OSSN has involved the corneal stroma already. That means that the patient will need either a penetrating keratoplasty or brachytherapy. So you can actually determine what kind of management you want to do based on ASOCT and UBM signs. The only fallacy of these imaging modalities is that if there is a lot of keratin, then that causes a shadow artifact. So you will not be able to judge the posterior extent of the lesion, although that will not interfere with your diagnosis. Now, systemic associations are also to be known: xeroderma pigmentosum, HIV/AIDS, post-organ transplantation immunosuppression, and palmoplantar keratoderma are the associations. And in xeroderma, you have bilateral lesions in teenagers, which are multifocal and recurrent. And even in patients who have immunosuppression, HIV positive or immunosuppression of any etiology, they have multifocal bilateral lesions, and they can also have skin papillomas, as this patient with organ transplantation has. This is a case of palmoplantar keratoderma. You can see keratoderma very clearly, and also they have abnormality of the nails as well, toenails, and have ocular surface cumulus neoplasia. I'll skip the AJCC8, it is not very relevant to this audience, but I'll very quickly go to melanocytic tumors. Which conjunctival pigmented lesion would you worry about? There are a lot of conjunctival pigmented lesions. This is a very simple classification. Complexion associated melanosis, or based on the skin pigmentation, that's called CAM. It was earlier called racial melanosis, which is not a very nice term, so we have shifted the emphasis on complexion, not race, which is also not a good term anyway, but it has to be there. Primary acquired melanosis is called PAM. They also call it CMIN, that is conjunctival melanocytic intraepithelial neoplasia. Secondary acquired melanosis is called SAM, which could be actinic. That means you get yourself exposed to sunlight, you are an outdoor person, and you have conjunctival pigmentation. Or you are a farmer, you spend a lot of time outdoors, you get conjunctival pigmentation. That is actinic. Reactive: a child has vernal keratoconjunctivitis and has conjunctival pigmentation, that's reactive. Use a lot of anti-glaucoma medications or medications which have a lot of preservatives, you have reactive pigmentation. Depository: somebody is fond of using makeup around the eye and this pigmentation gets deposited in the conjunctival epithelium, that is depository. Adrenochrome containing anti-glaucoma medications such as epitrate that were being used when we were residents can cause depository pigmentation of silver. Systemic diseases, Oguchi's disease, etc., can cause pigmentation. Nevus, melanoma, and scleral pigmentation. Very quickly moving on to these pigmentations. Now, if you have a patient who has bilateral conjunctival pigmentation, both eyes there is pigmentation, you go back home and look at your parents, you'll see that all of them will have some amount of conjunctival pigmentation. Your children may have conjunctival pigmentation. That is all complexion associated melanosis. That is seen in all of us. All Asian Indians will have complexion associated melanosis. But if it is unilateral like this, as extensive as this, then you worry about it. So you don't worry about bilateral conjunctival pigmentation, but only when it is unilateral like this, you worry about it. And when it is fleshy like this, again you worry about it because it is melanoma. So whenever there is extreme amount of vascularity, blood vessels coming from all directions to feed a hungry tumor, there is a lot of vascularity, so much so that this pigmented lesion has become fleshy and it is dark charcoal black or dark brown, then it is a conjunctival melanoma. Now, these are typical features of complexion associated melanosis. It has this cobblestone kind of an architecture, some amount of symmetry. It may not be exactly mirror image symmetry, but there is some amount of symmetry in terms of the extent of pigmentation. Then it is complexion associated melanosis. You simply observe it. Any amount of gross asymmetry is primary acquired melanosis. This is not complexion associated melanosis. This is primary acquired melanosis because there is asymmetry. Primary acquired melanosis occurs in unilateral situations, middle-aged individuals, flat, there are no cysts, and it is peppery. So basically it looks like as if there is a dusting of pepper on top of the sclera. So whenever there is asymmetry, you have to rule out primary acquired melanosis, and in such situations we should look at the fornix as well because it can extend to the conjunctival fornix. So peppery architecture, unilaterality, involvement of the conjunctiva beyond the interpalpebral vulva conjunctiva into the fornicial conjunctiva, all these are features of primary acquired melanosis. Very clear peppery architecture. Why is primary acquired melanosis important? Because about 10 to 30% of them convert to melanoma. And the most common origin of melanoma is not nevus, but primary acquired melanosis. When it is small, because each clock hour adds a risk of it being melanoma. So if it is small, less than 1 clock hours, you simply watch. You do nothing about it. You simply observe the patient. If it is more than 1 clock hour, say in this patient there is about 6 to 7 clock hours of involvement, the risk is 12 times high. 1.7, it's the odds ratio per clock hour of involvement. Then you treat. How do you treat it? You excise all the involved conjunctiva and do cryotherapy to the excision edge. Or if it is very extensive, then you do map biopsy of the conjunctiva, find out which areas have atypical nature and excise only that, or use topical mitomycin C. These are the treatment options. These are all various extents of PAM which you should be looking for. Very extensive PAM. And whenever PAM is not treated or it is ignored, it will very soon develop into a melanoma. The incidence of conjunctival melanoma, 75% of which is contributed by PAM. Only 20% are de novo and only 5% arise from a pre-existing nevus. So this is a very stark data that you have in front of you. This is true published data. This is a patient who has a phonacial PAM and this nodule is a melanoma that is arising from it. This patient has an inferior phonacial PAM and that nodule is a melanoma. So PAM can definitely give rise to melanoma. This is a patient with extensive PAM and you can see popping out melanoma there. This is a different way of classifying PAM which I will not go into. Alright, coming to a very common lesion, conjunctival nevus. I have 4 pictures in front of you. Can any one of you guess which one is not a nevus? Is it easy or is it difficult? Let's just name it A, B, C, D. Now which one is not a nevus? Well, we can keep guessing. Most of us will be right when you guess it. But if this patient is sitting on your chair on Monday morning when you all go back to the clinics after AIOC and you have to take a decision as to which one is a nevus and which one is not a nevus and you have to commit to a treatment, how do you do that? Well, we have a clinical checklist and clinical checklist is very simple. If it is located in the interpalpebral bulbar area, if it has variable pigmentation starting from tan brown to dark brown, there is no corneal epithelial invasion, it respects the limbus, stops just short of it. It has no episcleral fixation. If you move it with a wet cotton tipped applicator on the sclera, it moves very nicely. No intrinsic vascularity, feeder vessels are bound to be there, but there is no blood vessel within the lesion that you can see. The lacy network of blood vessels is absent. And more importantly, presence of microcysts. If you go back to this, you may argue with me saying that, oh, this has corneal epithelial invasion. No, it is like a fat belly hanging onto the belt, hanging beyond the belt. It is like a huge nevus which is overhanging the cornea. If it were to have epithelial invasion, it would be ragged edges like this. It would carry pigmentation and vascularity along with it. This one does not have interpalpebral vulvar location, but it has variable pigmentation and it is respecting the limbus. So all these are nevi of various types, but all of them are definitely nevi. All of them have been excised and I have the histopathology to back me up. So these are definitely nevi. There's no doubt about it. Last bit I was telling you about was the microcysts. These are the microcysts. In pigmented eyes, microcysts can sometimes be masked by the pigmentation. That is why you can again depend on anterior segment OCT and UBM to see if they have microcysts or not. This patient has microcysts. This one has macrocysts. Presence of microcysts and macrocysts confirms the diagnosis of a nevus. Nevi are spongy. They do have microcysts and macrocysts. Melanoma is solid. It does not have any of that. This is just some data to back up what I said. This is data from the literature. Most of the nevi occur in the bulbar conjunctiva. Most of the nevi occur in the temporal vulvar conjunctiva. This is from data. Now, how do you use all this that you just learned in a clinical situation like this? This 11-year-old child of very aggressive physician parents is brought to you with a fleshy pink conjunctival lesion which they have noticed only 2 weeks ago. They have read the literature, they are doctors and they have found that, oh, this has a blood vessel feeding it, so it has to be a malignant lesion. They are worried. So how do you commit to them? How do you go about it? 11-year-old child, for the first time parents have noticed it. And it has unfortunately involved the corneal epithelium just by 0.1 millimeter. Right? So simply do a test. right? OCT shows microcyst, so it's a amelanotic nevus. Preteen children do have amelanotic nevus, and as they go through their teenage years, it acquires pigmentation, it becomes classic nevus. So use your imaging very effectively to diagnose that it is an amelanotic nevus. Nevi can also be bilateral, as you see here. Now, cysts are seen in a nevi in about 2/3 of patients. Cysts are clinically seen if it is less pigmented, but otherwise it is seen on imaging. Cysts are not pathognomic of a nevus. Cysts can be present in lymphangiectasia and also mucoepidermoid squamous cell carcinoma. Should be very clear what you see. And when a cystic lesion turns solid, that means that it is turning into a melanoma. This nevus always had cysts, but one portion turned solid, and that was a new melanoma that has grown out of a pre-existing nevus. We know that 5% of nevi turn into melanoma. This was a teenage child. When I saw him first, he was absolutely fine. He had a supranasal nevus, and we followed up for 5 years, and then he went into college to a different city. After 6 years, he came back with a new growth from a pre-existing nevus, which was much darker, fleshy with subconjunctival hemorrhage. And it also had very aggressive vascularity. This was the nevus that he always had, and this was a new growth arising out of a nevus. Just to show you how effective imaging is, we did his imaging and also excised it and did histopathology. This was the solid component of the lesion. That's the cystic component of the lesion. Cystic component is nevus, solid component is melanoma, and that is the zone of transition of the nevus into a melanoma. So what you see on imaging mimics histopathology, and that's why imaging is very important in a pigmented conjunctival lesion as well, as important as it is in epithelial lesions. Now, we already showed melanomas, and all that palpable conjunctival involvement is also known, so you should look for that as well, and that's a nodular variant of melanoma. This looks very aggressive like a melanoma, but it is actually a balloon cell nevus. You can see a white sclera. There is no vascularity at all, although it looks clinically very dangerous. It's just a balloon cell nevus. See how dangerous it looks, but it's simply a nevus. This is also pigmented, but you spot bits of keratin here and corneal epithelial invasion, so it's a pigmented squamous cell carcinoma. This is some of the differential diagnosis for a pigmented conjunctival lesion. This is a true story. This young lady came with her fiancé asking for her eyes to be made white because she has a nevus and they don't like it. Both of them didn't like it. Do you see anything abnormal here? She has a steamy cornea and her pressure was 38. And she has an iris lesion as well. So this was an extraocular extension of a ring melanoma of the iris and trabecular meshwork. She had a white eye because we had to enucleate her. She had an extensive melanoma. And finally, she had a prosthetic nice white eye. So you can easily get fooled by a small conjunctival lesion and miss what is underlying. So you have to do gonioscopy in any patient who has a large scleral nodule or a pigmentation. That's a patient with pigmentary disorder where the melanoma can be amelanotic. And that's not melanoma, that is neither a melanoma nor a nevus, that is episcleral or scleral pigmentation in a patient with nevus of Ota. Right? So ocular melanocytosis can look like a nevus, but that is scleral pigmentation where you should be looking for uveal melanoma and not anything else. So we started about 10 minutes late, so I think I have about at least 5 minutes to 7 minutes to complete the management. I'll very quickly go through the management. Management, I think, is very simple. If you have learned how to diagnose a lesion, management becomes very simple. Now, when we consider or talk about management, we always begin with topical therapy. For ocular surface squamous neoplasia, topical therapy is the easiest to do. It is very extensively practiced, but the criteria is that you should have a clear clinical diagnosis. You cannot do a biopsy just to confirm a diagnosis. So whatever I've said in the last half an hour, 20 minutes, is the background on which you can start your treatment. If you haven't registered that earlier part, then you obviously will not go ahead with the management. These are the drugs that are used. Chemotherapeutic drugs are mitomycin and 5-fluorouracil. And immunotherapy that is used is interferon. These are the chemotherapeutic agents, and that is the immunotherapeutic agent. Now the dose that is used, you often keep asking. In mitomycin, it is 0.04% or 0.4 milligram per ml. QID, 1 week on, 1 week off is one protocol. The second protocol is rule of 4, 4 times a day, 4 days a week for 4 weeks. That is one cycle, after which you give a gap of 2 cycles. So 2 weeks. So there are 2 rules in mitomycin, 1 week on and 1 week off, or 4 times a day, 4 days a week for 4 weeks. And then you give a gap of 2 weeks. In 5-fluorouracil, it is 1% drop. It comes as 5%, so you dilute it, make it 1%. QID, 1 week on and 3 weeks off. That is one cycle. In interferon alpha 2b, it is 1 million international units per ml. It comes as 3 or 5 million international units. You simply dilute it using any tier substitute and make it 1 million international unit and dispense it. Patient uses QID, never stops it till you tell the patient to stop it. Minimal response time. So when do you assess the response after starting this treatment? For mitomycin, it is 1 cycle. When the patient comes back to you after completing 1 cycle, you compare the photographs. That is the best way to assess. You take pictures, nice pictures, not on your mobile, but good slit lamp pictures, and compare head-to-head photographs. And if there is good response, then you continue. If there is no response, you have to change your strategy. In 5-fluorouracil, it is again 1 cycle, and interferon, it is 6 weeks. So if there is no response within this minimal response time, you either shift to surgery or shift to any of the other drugs. If you begin with 5-FU, you can shift to interferon. If you begin with interferon, you can shift to 5-FU. If you begin with 5-FU, you can shift to mitomycin. So some tumors are not responsive to one drug, so you have an argument to shift to another drug. But don't use 2 drugs at the same time. That is not acceptable, because there is huge amount of corneal epithelial toxicity. Maximum duration. This is a question that is often asked. How long can we use it without causing complications to corneal epithelium and the limbal stem cells? In mitomycin, it is 3 months. It is most toxic to corneal limbal stem cell and also corneal epithelium. In case of 5-fluorouracil, it is 6 months, and in interferon, it can be indefinite. You can continue it forever. How is interferon used? It's used in 3 modalities. Immunotherapy is to completely eradicate the tumor. Immunoreduction to reduce the tumor size and then do surgery. Immunomodulation is to enhance the local immunity of the ocular surface so that the patient does not have local tumor recurrence. So small tumors like this can be completely cured with topical therapy. This is called immunotherapy or chemotherapy, where the intent is to completely eradicate the tumor. You don't intend to do surgery. Your intention is to completely eradicate the tumor. Also, tumors which are recurrent. This was a small tumor in the background of prior surgery. Small recurrent tumor, completely eradicated with topical therapy. Corneal ocular surface squamous neoplasia is a specific indication for topical therapy. In this patient, this is my favorite slide. I would like to demonstrate one important finding here. This is an area where my cornea specialist colleague had done a biopsy before he sent the patient over to me. Rest of the tumor was taken care of by topical therapy. 3 years later, you can see exactly in the same area where a very competent cornea surgeon had done a biopsy, there is a small corneal scar. Which means that if you were to do primary surgery in this patient, the ocular surface of the cornea in the pupillary axis might have had a small scar, thus reducing the visual acuity of the patient. So there is an indication in patients with corneal avascin to do topical therapy, or in patients who have a tumor right at the corneal graft host junction. So this is a patient who has xeroderma pigmentosum, other eye is blind. This is his 3rd graft, and on top of that he has a OSSN at the graft host junction, where if you were to do surgery, you may tip the balance in favor of a graft rejection or a graft failure. There you use topical therapy. You can see how cornea has become very clear following topical therapy. Or in patients who have more than 6 clock hours of limbal involvement, where if you were to do primary surgery, there would be a possibility of limbal stem cell deficiency, where you have a scarless healing with topical therapy. That's the 3rd indication. And the fourth indication is diffuse OSSN, where almost the entire ocular surface is involved. If you have a tall lesion like this, I would prefer surgery. But if I have a flat lesion like this, I would prefer topical therapy. And this took about 6 months of patient use of topical interferon, but there is no need for surgery here at all. So you should choose your cases. If you have a patient where there is a tall lesion like this, then possibly it is not a good case for topical therapy. You should possibly do primary surgery. Immunoreduction is a principle where you reduce the size of the tumor before you do surgery. Now this patient has an extensive tumor, very large tumor, which is flat. Of course, you can excise it. But upon immunotherapy, what has happened is that the tumor has become much smaller. And why does that happen? If you consider this as the epicenter of the tumor, that is limbus, that would have the invasive squamous cell carcinoma component, or around it. Around that would be a zone of carcinoma in situ, severe, moderate and mild dysplasia that is followed by normal conjunctiva. So what topical therapy does is it takes care of all the dysplasia and carcinoma in situ, and finally what is left is invasive squamous cell carcinoma component, which is refractory to topical therapy, that you will excise. You don't excise the entire ocular surface just for the sake of excising it. So if you have a critical situation where vision is very important for the patient, other eye may have been blind or having amblyopia, etc., there you want to have minimal surgery. That's the reason why you do immunoreduction, and finally immunomodulation in patients who are predisposed to these tumors. So case selection is very important for topical therapy. Whenever you have a diagnosis in doubt or whenever you have a scleral invasion, you don't want to use topical therapy at all. Quickly about surgery. Surgery would mean excision with edge as well as base clearance. Edge is very easy to detect. You see the patient on slit lamp, stain the tumor with rose bengal, you have the entire edge visible, beyond which you go 4 millimeter and you're done. But what about the base? Base has to be assessed on imaging sometimes, because on slit lamp you may not be able to assess the base. So you have to do imaging to see how deep the tumor is, and then you excise it. That is how you deal with the base. This case I earlier showed that this involves a corneal stoma already, so excision is not the cure for this patient, and we have a habit of making these large conjunctival diagrams like the retina diagram that you have seen to map out the entire extent of the tumor. So excision becomes very easy. I'll skip the surgery. Results are very evident, results are very good. In fact, surgery is one of the best options. But there are some situations which are beyond surgery. Patients who have scleral invasion, earlier we would do enucleation, extended enucleation or orbital exentration. Now we can rescue these patients with plaque brachytherapy. Extensive scleral invasion. Suppose this is the eye and this is the scleral invasion. What do? You do a flush excision along the sclera without disturbing the sclera or doing sclerectomy. On top of the bed of the tumor, you apply brachytherapy, which is either ruthenium or iodine. And you can see results like this. This is secondary plaque brachytherapy. So what we do is we excise this tumor without any lamellar scleral dissection, and on the bed we apply plaque for the duration of exposure, and then that is the kind of results you get. It's only 2 millimeter thickness that you're treating, and it is very safe. Radiation is very safe. You get tectonically strong sclera back. There is no perforation. Risk of perforation is almost zero. But when you have a stromal melt already, like this patient has a stromal melt, can you do surgery in this patient without causing corneal perforation or scleral perforation? You cannot. There you use primary plaque brachytherapy. You apply plaque right on top of this necrotic melting tumor, and again you will get good results in a majority of situations. So either you excise it and put the plaque, or without excising it, if you can have that kind of a dosimetry support by your radiation oncologist, you can put the plaque. Results are the same. This is a patient with melanoma with scleral invasion that completely gone with plaque brachytherapy. So plaque has come as a boon to us for ocular surface tumors. This is an extensive tumor in a Kashmiri patient who had 3 times excision elsewhere, and he wants vision. He has 6/6 and 6 vision already, which he wants to save. That is the extent of the tumor that we have, melanoma with unfortunate intraocular extension and ciliary body invasion. These are the ciliary processes that you see. We could have easily exenterated him, but he wanted eye salvage. I'll skip the video again. Again, we use plaque brachytherapy, but the rotational technique where we treated every bit of the surface of the eye with brachytherapy after excision, and he looks good after 3 years of follow-up. So Brachytherapy has about 90% success, which has been recently published in British Journal of Ophthalmology. Even in desperate situations like this, where it's scleral invasion in a young individual like this who wants eye salvage with choroidal detachment, retinal detachment, you can see the extent of the tumor with ciliary body invasion. Our radiation oncologist can design stereotactic radiation for him with chemo-augmented, cisplatin-augmented radiation, and you can see nice results. Choroidal detachment, retinal detachment have settled, and his intrascleral and scleral invasion have gone, and his ciliary body extension is also gone. So there are very good treatments that are available for squamous cell carcinoma currently, and only these desperate situations need orbital exentration. So I think our time has ended much beyond what is permitted. Thank you so much. Yeah. Where do you get the plaque? BARC, Mumbai. We have made a plaque, Indian plaque. So it's made by BARC, Bhabha Atomic Research Center, and they can supply it if your institute is radiation approved. That's right. That depends on the radiation dosimetry. We have a software which calculates the dose and the duration, and based on which we do. It's about 48 to 72 hours for conjunctival tumors maximum, even 24 hours sometimes. They are involved, but the majority of work is done by us. They are theoretically there, but practical work is all yours. Brachytherapy source used to be 10,000 US dollars, but the one that we have made is 50,000 Indian rupees. So it's like 5% of the cost. We have two sizes. One is 12 millimeter in diameter, another is 16 by 20. We have other sizes also in the making. There's a pediatric plaque with 8 millimeter diameter that is already made. We are making other designs as well. So size is not a limitation. You can use the same plaque in different locations. You can combine two plaques. So size is never a limitation. You need to first get your institute approved for radiation. Yeah. Then you can contact. No, it is, radiation is incorporated within the plaque. It's ruthenium. Ruthenium is a radioactive source. They are there for safety, and the radiation physicist calculates the dosimetry for you.
Because the plug actually radiates by itself, and we are going to stitch the plug onto the sclera.
Correct.
And that's it. After that, we don't need to do
so
anything.
These are government rules, safety rules. Government treats ants and elephants by the same yardstick. Ruthenium is least harmful. I've been using ruthenium since 2004. That's 20 years. And I don't have any radiation exposure, documented radiation exposure, because I have to carry the TLD badge in my pocket and my wrist all the time. My radiation exposure is negligible so far. Every surgery we measure our radiation exposure. It is negligible. All right. So, but then the rules are the same. You have to have a radiation physicist and a radiation oncologist. Anita knows about it. She has set it up in our hospital. It is very, very stringent. Very stringent.
So, do they send it autoclaved, sir, or do we
have to autoclave every time.
Get it, autoclave it, and then use it.
Yes.
It comes with the holes, is it, for us to?
Yes. It comes with everything.
Okay. Thank you, sir. Thank you.